you, Anna. I want to start out by saying that normally when I talk about foster care public health nurses, it's a 4-hour lecture. So I've condensed this down to 5 minutes like Anna asked. And I'm going to just hit some highlights here. So first of all, I like to explain to people that in the state of California, public health nurses are nurses with a Bachelor of Science in Nursing. They have an RN license and they have a public health nurse license. That's a little different from other states, but I like to let people know actually what a public health nurse is, because oftentimes there's confusion. And the other thing is we have a specialty in looking at community problems. We look holistically at individuals within their environment, whatever that may be. And we like to focus on prevention. So this works hand in hand with child welfare and probation. If we can prevent problems within the system, with the caregivers, with the youth, that's always best. So lots of times our recommendations and consultations come from that perspective of prevention. The other thing is, as I mentioned before, we look holistically at the situation. Oftentimes we think of nursing as just physical and oriented to provide skills. But in fact, we look at the psychosocial, the developmental, the mental health, educational, and dental, lots of other aspects of a child's life. Including in that, however, the bill that governs our work actually says that we are to be placed within the child welfare system. So we're sitting right there with the social workers and probation officers so that we connect with them on a regular basis, and they can hear us, we can hear them, and it's so easy to coordinate care at that point. The other thing is that we're available for these consultations, not only for the social worker, but for the caregiver, teachers, school nurses, foster parents, providers. I know when I was working, providers had my personal cell, I had theirs. And that's one of the other strengths that come with this job, is that public health nurses know the resources in the community. And that's a real strength in terms of coordinating the care for our youth. And finally, I want to say that we love this job and we think of these children as our own. And so we're going to make recommendations based upon that feeling and that heartfelt love of what we do. So thank you, Anna.
Thank you, Susan. And if anyone has questions, please just continuously type them in the chat. And we can ask questions throughout and at the end, and we'll be doing breakout rooms as well so that we can ask questions. So please type your questions in. So the next thing that I would like each nurse to cover is just how you would like caregivers or case managers to reach out, or youth to reach out and request support. And how would you suggest to caregivers to introduce a youth to their public health nurse, or to let them know that they have one? So how would you like that conversation? And Susan, we can start with you and then kind of move through.
How they could approach the nurse?
Yeah, so if I'm the caregiver and I have a new youth in my home, you know, how would I know who their public health nurse is, and how would nurses like to be kind of contacted when an issue arises, those sort of connectivity things?
Well, first of all, the nurses love to hear from the caregivers. We want to be involved. We want to help. We want to prevent any issues. And I know in the counties that I worked with, a letter from me went out to the providers with my name and phone number so they could reach me. And I always made sure that I could give them the most up-to-date health and education passport. And sometimes they just wanted to call and be heard and just talk about, it was a tough day. And we're available for that too. Nurses are trained in therapeutic listening. And so there are so many aspects that we're a phone call away. If they don't know the phone call, they could call the child welfare department. They could call the CHDP department in different counties. And I think now John Burton has a list of all the nurses within the state. And that's another way to get a hold of a nurse. And we do answer our phones. It's a priority for us to call people back. And so that can sometimes be a surprise to a foster parent.
Thank you, Susan. And do any of the other nurses, I know Kristen, you're here from Orange County. Is there anything different about that? Or how would you recommend folks reach out to get in touch with you?
Hi, thank you. On Orange County, there's kind of several different ways. We obviously have kind of an open door policy. We have nurses that are housed in specific programs. So for our kind of, I know we don't call them group homes anymore, but for our children that are placed in STRTPs, kind of our older youth, we have a specific program, our Permanency Services program, and we have 2 PHNs that are housed there. So we give out their information. We also kind of have a general hotline to reach foster care nurses so that if you are a caregiver, it doesn't matter what program that you're in or where your child is housed. If you need the assistance of a public health nurse, you can kind of reach out that way. Additionally, we get a lot of our referrals from the assigned social workers. So if that's kind of their main point of contact, and because they have more hands-on involvement consistently with the cases and meeting with the youth, they're kind of a lot of our point of contact for what might be issues are. So they'll reach out to us, caregivers having an issue with this, please connect with them. But there is several different ways in which they can kind of reach a public health nurse. And so we kind of give out all those different resources, and we're working to develop our placement packets to have more information on how they can reach us to help with those preventions. So it's not always an emergency at the last minute, and so they can feel better supported that way.
Thank you, Kristen. Are you able to put the hotline in the chat for us?
I will. Thank you.
Awesome. And let's go to LA, either Cynthia or Tanya. Is there anything specific to LA or how you would prefer folks reach out? So yeah, just let us know.
Hi. So since I handle probation and court, which is a little bit different from Tanya, which later on, because I think Tanya is also dealing with the DCFS part of it. So it's a 2 different ballgame. In probation, all the kids are placed in STRTP homes, and also RFA, relative homes. So what we usually do is all the nurses with their, we handle, nurses handle by STRTP. It's not individually. So one nurse can be assigned to 5 STRTP. So all our contact is being sent to STRTP at the same time, probation and probation management. Now, as a public health nurse in a foster care, we are the consultant. So probation is the main caseworker, but still STRTP kind of reached to us. But I always make sure that probation knows what's going on with the kids. So all our telephone numbers and everything, who is in the whole 5, there's about 5 of us as a probation, and we are housed in Telstar. We have all our contacts, cell phone, email, and everything given to STRTP, the probation and probation management. Now, if a caregiver in RFA, every kid in RFA is being assigned to a public health nurse. Public health nurse will also, when necessary, call that RFA and make sure that she has the contact of our RN. At the same time, the probation who is covering for that. Now in DCFS, it's kind of different ball game because each of the kids is assigned to a social worker and a social worker to a PHN. Each of them, it's not by group, it's not by STRTP. So usually majority of the contact, because social worker is the main, the primary caseworker, and we are the medical consultant. Everything goes to social worker, and then the social worker will give all the information to the nurses. Like if they need a referral, then the nurses then can go ahead and usually call the caregivers, give them the phone numbers. That's all our phone numbers on the DCFS part is the social worker and the management have it. Tanya, do you have anything to?
I agree with you. And on the probation side, we actually contact the RFA homes. Basically, we've been doing it in response to COVID-19. So we'll kind of call them and just check on their status if they have any symptoms. So we've been kind of proactive, and that's the RFA homes. On the DCFS side, it's a huge volume at this time because about 40% of the nurses in my office have been deployed to do point of dispensing on the vaccine, the COVID-19. So we all were required to do about 10 hours a week in the COVID efforts, to meet the goals of the public health. So it's a little bit different, and the assignment has changed. And when you look at the PHN, the workload situation, the workforce, you have right now all of the public health nurses in the Department of Children and Family Health Services are carrying about 6 units, and a unit is comprised of a supervising children's social worker. So this one supervisor has 6 social workers under her. Those 6 social workers all have about 15 kids each. They used to have 25, but they decreased their caseload. So let's say there's 90 kids in each unit, and the nurse has maybe 6. Right now, everybody has 6 units. So that's 90 times 6, about 540 kids. So we more or less, and the assignment is changing a lot because it's a kind of a fluid situation right now. But right now we're depending on our caseworkers to bring it to consult with the public health nurse. So they're really good about that. They do consult with us. Hey, I need help with this. And if we see a high risk situation, we will flag it. And during the times when, before this COVID situation, the social worker used to bring the youth into the office sometimes, especially during placement or going to a new caregiver. There were meetings. So there were opportunities for the public health nurse to actually meet face-to-face in the DCFS office. And especially the male social workers may want to have the nurse interact for reproductive health and sexual health education, just to reinforce that, because they're going to, basically education is going to take place in the middle school and high school comprehensively, but the nurse is going to reinforce that and actually give them an opportunity to be one-on-one with the nurse.
Thank you so much. And then for Fresno, Lupi or Michael, do you want to add anything specific to Fresno County, how you prefer folks to get in touch, or what the best way is? Lupi, it's not working. You might want to try your computer. I'm not sure why the phone's not working.
Can you hear me?
Yes.
I'm so sorry. So in Fresno County, we have approximately 2,600 youth in foster care, and we recently hired Stella. So we have 9 PHNs, and one unfortunately is transferring to COVID full-time. So the nurses are in different departments. We have one that's stationed at JJC. We have a couple that are in CFT teams. We have two other nurses that are in ER. We have Michael that's in psychotropic oversight. And we have a couple of other nurses. One's in adoptions and the other one's gonna kind of help out everybody else. But I'm one of the nurses that's situated in ILP. And so if ILP is basically a place where youth can come in and access services. And one of the services that they can provide or tap into is the nurse. So anything that has to do with medical, reproductive health, anything. It could be that they need to be tied in with a provider. Also, there's 3 ways that like group homes can contact the nurses. One of them is they can always call me because I'm on, this is like our ILP newsletter and my name and my number is at the bottom. Another way is we have a main line where providers or group homes or foster parents can call. And then someone will call them back or they will connect them to a nurse that can assist the person that's inquiring about the youth. And the third way is, for example, if a group home or a foster parent has like medical records from a doctor's visit or any type of like a dental appointment information, they can always fax that information to us. So they can reach us by the line. They can always walk into ILP or call me directly, or they can fax over information regarding the youth. So,
Thank you all so much. Does anyone have questions about, how to get in touch or anything like that? I know we have nursing staff here from some of our STRTPs, and that can always be an amazing connection, nurse to nurse. It's such a strength of the program. So does anyone have any questions just on the best ways to contact? I did want to share go ahead.
Anna, I'm sorry. So this is Cynthia. So I forgot to mention that with the STRTP, the probation staff works with is we have a designated fax number. The STRTP fax all the medical, dental, and any medical information about the kid that goes directly to our designated fax, and each of the PHN that are assigned, because they know, STRTP knows which PHN is assigned to them, but it goes into one fax system where each of the each of the nurses, public health nurses, will retrieve their own records and work on that, and that's how usually they work on all the records that are being faxed on that, that's for LA County.
Yes, thank you. And one of the questions here is, does LA County have a main line? So you can see we're working on this roster here so that folks know who the current nurses are. They know there's been some shifts because of COVID caseloads or shifts in the county capacity. So we're kind of keeping this updated as we learn. So Stella, I would love to add your contact to this. You see we're adding right now the general hotline that we just got from Orange. But if there are other numbers, people, probation nurses, we'll add them by county, and you can see Northern. For Kern, Lynn, I know you're on the call. I got one contact information that we were able to. Kern wasn't originally listed in here, and we had to kind of find who the right contact was. But we're working on this, and we're working with the nurses and with the counties to make sure. We're adding this DHCS contact up here for the state. And we'll just kind of keep this updated as things shift. But so if you were working with a youth and then they're going to move to another county, or they're coming in from out of county, I think like what Whitney in Mary's Path, they get used from a few counties. So it might be nice to touch base with folks and cross when they come work with Kristen, now in
Yeah.
Orange County and they get reassigned, or maybe they stay. So I think this is one way we're trying to make sure people know who to call to get assistance, but also the case manager. So the case manager should have that information as well. But if something's more timely or urgent, this roster is here for you. So the next thing that I would like to cover, I'm going to stop sharing my screen here, but I did put that roster into the chat here, and I will send it. We're making a public health nurse page for our website. So we'll have more information to share later in this spring season here. So the next thing for our learning community here, as you heard, a lot of the folks on the call work with expectant or parenting youth. And I'll also work with youth who have experienced criminal or sexual exploitation or trafficking. Our youth in care are at greater risk for STI. And also for kind of not noticing or later detection of STIs. And so our nurses in the STRTPs and caregivers kind of have a lot to kind of look out for, especially when someone's entering or exiting, to make sure there's care coordination. But for our nurses, we have a couple of nurses on the panel who were also nurse family partnership nurses, and can talk about what are the types of things you're looking for, services you refer to, what's kind of an emergency, what's general care. So I just want to hand it over to just sort of talk about the types of care and services that are aligned for those different types of scenarios. And Luke B, I'll have you start since you were both a foster care public health nurse, but also work with nurse family partnership. So, and then I'll turn to Tanya, who also had that experience. So we'll go in that order.
So like I mentioned before, I'm stationed in ILP in Fresno County, and youth are able to either, right now because of COVID, they do have to make an appointment, but next month it's going to be open to the kids. They can walk in, and I always have an open door policy. They can always walk in, because I don't want it to be like a lost opportunity for them when they walk in and I'm not here or the door is closed. But I do get all these interesting kids with interesting questions. It can be from basic female human anatomy. They have no idea, and they're asking questions regarding that. I do get questions regarding the different type of birth control methods that are out there. And I have condoms here in my office. I have them in the restroom so they don't have to feel ashamed to take some and take them with them. One of the things that if I'm made aware that a youth is pregnant, I do have her sign the minor consent form so we can have that discussion. I do try to link her, if she's not already linked, to an OBGYN. Also, I encourage the youth to sign up for nurse family partnership, early hits, but focus forward. Or we even have, like here in Fresno County, we have Varios Unidos, which is like a teen success group, which kind of encourages these youth to kind of like stay on the right path and go to their appointments. And there's other teens their age. And also just recently, we're going to start this 6-week pregnant and parenting youth group. And it's going to be a good group because I'm going to be with a social worker, and we're going to have activities. And I think what I've seen in the past is I've had these classes before, but I think they want more of a activity, fun, plus teach me. Because if I put it in the ILP newsletter, oh, we're going to talk about SIDS, and we're going to talk about shaken baby, and we're going to talk about immunizations, I think to them, it just comes across as a little bit too dry, or, oh, I already know that, and teens thinking that. So by teaming up with this social worker, I'm hoping that it's more enticing, more exciting, and hopefully I'll get that group of kids coming into the classes. But I do try to make sure that they're tied in with a program such as NFP, which is a great program. Stella, the new nurse that we hired here in Fresno County, she worked, correct me if I'm wrong, Stella, 10 years in that program. So she's very well versed. And it's very, I think the whole goal is to empower the youth, the teen, that and along with the 2 year of home visiting is to make sure that she knows that she's not alone. She has a mentor, she has a nurse, she can nurse any question. It can be very touchy-feely, very emotional, but also at the same time very educational for the youth. So.
Yeah, I was with that program for 8 years. Yes.
Yeah. And honestly, a lot of the girls that I see in Fresno County, when they say yes to the program, some of them will hang for maybe 2-3 months, and then they kind of say no thank you anymore. But some of them, they're very successful in that program, and you can see the difference because NFP is like a very what is it? So it's very empowering, and that relationship that they have with the nurse is so strong that they listen to the nurse. And if they're getting all of this information from YouTube, their friends, maybe mom is in the picture during visitations and she's informing her of, information that's not correct. But having the nurse going out to the home, educating her, and she has these questions ready for the nurse, I think it just clears up a lot of the, misunderstanding that she might have.
And public health nurses, when they work with the caregiver, can help make the referrals to those programs, right? So, if the caregiver is letting them know, this youth disclosed they're pregnant and they want support, then, letting the public health nurse assist with aligning programs. There's also programs for young boys or non-minor dependent young adults who are male identifying, right? So young fathers programs. Nurse family partnership is just for the mothers, but there's also linkages that can be made for parenting classes and parenting supports for the young fathers, as well as family planning and birth control options for young men. So I don't know if you want to add anything to that, but maybe also Tanya can share what you're looking for when someone is expectant and parenting.
Well, I agree with Loopy. The Nurse Family Partnership is a really good program, and we make lots of referrals there. And we do get a lot of referrals for expectant and parenting in the STRTPs. I would say St. Anne's, I've been there to visit face-to-face using, of course, social distancing and PPE. But just to kind of establish a relationship and, discuss their reproductive health and actually link them to other services such as NFP, or maybe get them linked to WIC or any other services that they might need, or later on the infant supplemental payment programs and any of those programs that's going to be beneficial for them. And the nurse really has as Loopy brought out, a therapeutic relationship, and it's based on trust. Of course, we're mandated reporters, and sometimes we get into some sticky areas there when we're discussing reproductive health. And some of it can get into like intimate partner violence and healthy relationships versus unhealthy. Because when you're talking about 14-year-olds that are pregnant, and the circumstances surrounding these teen pregnancies, but the nurse is basically there to help them navigate the system. And as brought out, link them to early prenatal care, because it's so important, because in that first trimester, a lot of things can happen. If you wait too long, maybe you're already drinking, exposed to alcoholic beverages, cigarettes, marijuana, everybody, all of that's being done, and later you're being linked to health care. So we want to really avoid all of that. We want to get them in early, so their initial lab, teach them what laboratory tests would be expected. Like, oh, I don't want to have lab tests done. You know, this is critical. So the nurse has a really good role there, that she can help them to have a better outcome to their pregnancy. And I've been fortunate because some of the probation officers, they will make consults. Oh, can you follow up with Susie? And so then they make direct consults to the nurse, and I've been able to do face-to-face visits. And because right now I'm not in nurse-family partnership, but I was previously, I know basically the curriculum and all, the information. And I also make visits to the juvenile hall and the camps.
Thank you, Tanya. And I don't know, does any nurse want to share about, when you're aware that a young person is sexually active, the type of things you're looking for around safe sex, family planning, birth control options, and STI treatments? I know for some young people, STI treatment would require multiple visits and timely visits, so that the doses of the treatments are sufficient to clear and treat the sexually transmitted infection. So what would you share with our caregivers or kind of nurse staff around some of those barriers and how you support with those?
Well, if they walk in here in Fresno's ILP, so there's been times where they'll come in, and these are girls that I've worked with in the past, and they'll say, my boyfriend told me he was diagnosed with an STD. What do I do? And so those are kind of like really like, yay, you came back. You're asking, where do I go? But we're able to refer them out. I mean, right across the street from ILP, there's an OBGYN that sees some of our youth. So we also have, EOC that offers transportation for teens to their clinic, or it's Planned Parenthood, and we have in the restrooms, again, maybe they're too shy to talk to me or they feel uncomfortable, but in the restroom we have the little flyers where it has the little map on how to get there. There's 3 locations here in Fresno. But if they ask me, I mean, we have lists of OBGYNs, we have pamphlets of where they can go and get some help when it comes to that. And also, if they're interested in birth control, it's always good to go over the different options, because sometimes if they do make an appointment, they're kind of rushed in and rushed out. So it's good for them to be well informed of what their options are. They can't just say, oh, I'm here for the pill, because they think that's the only, birth control out there. There's others, and having them well versed before they make, go to the appointment.
I was going to say that in regards to STIs, many of them are reportable. So let's say someone has their initial blood test and they test positive for syphilis, they're going to automatically get reported to public health department, the CMR report. So they're going to automatically be tracked instantly. And that woman may require serial blood draws, and also the baby may need treatment depending on the ratio of the blood testing. So then there's safety nets in place. So it's not going to be just the nurse. There's safety nets already built into public health to catch certain diseases and the follow-up. So the nurse is going to be a supplement, that they will treat these STIs. Some of them are treated instantly, like gonorrhea, chlamydia, you know, but others will require serial testing and follow up, like the ratio for syphilis. So those are already reported to the Department of Public Health instantly anyway. And then we will back up to make sure that the compliance is there, or that the person didn't AWOL somewhere, and we can get them back into treatment.
Mhm. Thank you. And I think for the caregiver, you know, for the STRTPs and the STRTP nurses, what you're looking for or screening for is, you know, that history of, you know, was there safe sex, you know, have they had a recent testing? Because, you know, I think the hardest part is getting the appointment for the test itself, you know, for both pregnancy and STIs. And I think that's why treatment is often delayed, not because the treatments don't exist, but because the relationship building, the connection that it takes for a youth to feel comfortable to disclose information is hard, especially when folks are newly coming in the door. It's a new relationship for them. So later, Alyssa's going to share from Hillside's their updated nurse intake protocol and talk about what nurses inside the STRTP are doing to kind of encourage conversations and get that relationship started so that the right services are matched. Yes, Cynthia.
So before I came back to foster care, I was school nurse. So I have all these kids. So one of the usually kind of identified problem with this kid who has STI that were identified and diagnosed. Yes, they can go get the treatment. However, sometimes they fail to ask whether the boyfriend or the sex partner has been treated. Because I find out that once I asked that and it didn't, then here we go again the second time around that they're having this. So it's very important to explain to them, even with the STRTP nurses, if there is somebody in there who has identified or diagnosed and they have that rapport already, to make sure that their partners get treated. Otherwise, it's just gonna go around. And I know it's usually being reported to STD clinic or you know, in the department, but sometimes they have a hard time, or they can track their partners or have a hard time tracking, but the compliance may not be 100% in there. So it's very important that that youth needs to know that, hey, if you're gonna have this, you're gonna get treated, but if your partner is not gonna be treated, or whoever gonna be your partner, it's gonna go around again. And so that's the one thing that I always emphasize with them when I was school nursing, you know, about this STI.
Mm-hmm. Yes, exactly. So thank you for sharing that. And I think it really kind of speaks to the STRTP role as well, where in the licensing standards, it states about the personal belongings, ability to keep birth control on your person and in your personal storage and not have it be confiscated. And a lot of that is because, you know, you could go in and be treated for an STI, your partner's not treated, you go on, you see them again, and now you need another treatment. And so it's really about creating the safest environment possible and improving the health of youth and those health outcomes. And there's a lot of collaboration that's needed from the different folks who are involved in their life to make sure they're safe, and that those don't become long-term or lead to long-term health complications. So thank you so much for sharing that. I'm just going to share my screen for 1 second as a reminder that we do have these listed of supports for parenting youth. Again, many of these are both for mother and father, you know, and the different options here. So again, linking the parent to the public health nurse helps to make these referrals across the board. So I will put that into the chat right now, just as a reminder of everything that's out there from education, health, parenting classes, parenting support plans, and all of that good stuff. Great. So next on the questions here, I wanted to talk about if Tanya or others can share, what are you looking for when we know some of our facilities are serving youth who have experienced criminal or sexual exploitation or sexual abuse, and that is their reason for being in care. So knowing that kind of sexual history, trauma history, and just the treatment and health issues that you see, which, as Susan mentioned earlier, can be both the physical health, sexual health, and mental health needs. So can you just share a little bit about what you're doing to support the youth and how you work with the STRTPs to support the health of the youth in those situations?
Are you talking to me? Okay. All right. I work with CSEC youth with commercially sexually exploited children, and exchange of sex for could be money or either something perceived of value. And these youth are very, very vulnerable. Many of them have already been, most of them have already been, are connected to DCFS in some way, or either have had a severe neglect, abuse, emotional, sexual abuse, and all of that. So they're very, very vulnerable, and these exploiters groom them in a certain way that they can get sort of a trauma bond towards them. So even if they, you can get them away from that situation, they may AWOL to go back to that situation. So then when you do have them in the STRTP, then we want to support them. They usually have an advocate and someone specially trained. In fact, LA County has special units for the CSEC youth. The judge is trained, is sensitive and caring towards the youth. They have specially trained social workers as well as probation officers, educational specialists that support them to recover their credits. Because of being AWOL a lot, they lose a lot of school credits, and we want to get them back to where they could be. And also mental health is very critical because of maybe post-traumatic stress disorder related to the circumstances they've been in out there. It's not easy out there in exploitation. So how we can support them is because you're going to see a lot of STIs in ways that you would never think. And it's going to be shocking to you, maybe. But we don't judge, we're unbiased, you keep a straight face during any of this. And you're just going to be empathetic because this is a form of child abuse. This is a form of child abuse. They are the victims of these exploiters. So what we're going to do is be supportive, non-biased, and respect their gender, and link them to care, link them to service, follow up. And the challenges are that there's a lot of absence. You can have the best case plan and set it all up and link them to every service available, but then somehow they're AWOL from the STRTP. So if they're gone too long, their bed might close. So they have to be replaced. And another thing is the nurse can support the whole case plan is by keeping the health education passport updated. We don't put any confidential information regarding the treatment for reproductive health and that kind of thing in there. However, just having the basic well-rounded all over care provides continuity of care. So that, let's say if they AWOL from the STRTP and they're going to be replaced somewhere else, when the HEP is updated with updated medical appointment, maybe the exploitation caused bodily injuries, such as being thrown out of a car or being in a fight or being attacked somewhere because of being on the blade or whatever. So when all of those medical problems are updated in the HEP report, then that's going to help the STRTP, because when they're able to get the person linked to services, generally when a person comes newly admitted, they're going to take them for a health exam with their own doctor within 30 days. So then that's going to provide more continuity of care. And then the sexual reproductive health will piggyback onto their all over wellness, because we want them to have total care. That way, you know, they'll be receptive to the information that we're able to provide.
Thank you so much. Do any of the other nurses, Kristen or others, want to add on to anything that Tanya shared in regards to serving CSEC exposed youth?
Well, I know in Fresno County, we do have a CSEC liaison social worker, and we have approximately like 60 youth that are pregnant or parenting. And I would say probably a fifth or a fourth of those girls are CSEC. They're identified as CSEC. And I agree with Tanya, they AWOL quite a bit. And so periodically we check to see if they surface, or so that's as much as what we do with CSEC, at least the contact that I have, unless they come in. And sometimes I do have one-on-one meetings with them, or have a home visit if I'm able to with them. But sometimes that's hard population to work with for me.
Yeah, I think it's really it's kind of the long haul relationship building where, you know, the information is provided, but it takes a while, you know, as we know with domestic violence as well, it can take a while to kind of be in a safer position. And so there's a lot of harm reduction approaches, and there's more and more trainings offered to STRTP and caregivers around that topic. But it is one thing that we've learned from this learning community that we would like more information on, and we're looking into adding a module to our online STRTP training on this topic that is around serving youth who have experienced criminal or sexual exploitation and trafficking. So we do know there's kind of a gap in some of the trainings and want to provide more of that in the future. So one thing I'll share here, just as a reminder of some resources for having conversations, you know, for caregivers, you know, so that this is kind of how you start the conversation, but again, working with the nurse and the professionals to link to the services that are needed, but kind of the different roles. And I'll put that in the chat. Talks about kind of how to have these conversations in a safe way in English and Spanish. Right now is what we have it. If you need it in a different language for anyone you're working with, let me know, and we'll work on a translation service for those so you can use those with your staff. So I'm also going to work on a training module that models these conversations and sort of how you would have a trauma-informed conversation with youth around sexual and reproductive care when there has been, especially for those who have abuse histories, where abuse feels normal. You know, I come from an abuse background, and it's kind of intergenerational in my family. And so it took me a while to kind of unwind that tape of low self-worth and some negative messaging and even some values and having that voice. And, you know, I'm in my 30s now, but certainly in my 20s, I still had a lot of behaviors that were dangerous and I needed help. And it took a while to bring those into my real life. So I do feel for you all in that way. Cynthia, you wanted to share something?
Yeah, coming again, I know even if it's not CSEC, but those pregnant minors coming again from a school background, one of the things that I think STRTP also needs to be aware if they're taking care of these pregnant minors is the fact on how to identify kids who are in abusive relationship with their boyfriends. Now, to them, majority of these teenagers always think, hey, he beat me because he loves me. Okay, that's a lot of misconception that I used to get from the pregnant minors. No, it's not really abuse, it's because he loves me. He doesn't want me to do this, and controlling issues and everything else. Now, to identify that, even if you are in an, working STRTP, is a very crucial, because you can save to them. They're very young, so there's not really an abuse in there, but technically once that happened and it goes into a ball game, it rolls and rolls until it is to the point wherein, hey, how come you have this, like some physical, oh no, he just want me to do this. Or sometimes I have their boyfriends coming into the school to eye on them before. So I have to do a lot of reporting on these things. And yeah, that's one thing that like teenagers usually need to understand. And a lot of them will have a PTSD after this. So I think that's one aspect that we can at least help them. I mean, oh my gosh, as a school nurse, I got a ton of things.
Thank you so much. I'm not seeing any questions in the chat yet, but I know we're going to move to breakout rooms after kind of 2 more conversations that we wanted to have. So one is from Michael Hughes, who is a psych meds monitoring and oversight nurse. So again, how is this tied to reproductive and sexual health? Well, some medications have like interaction effects, so it's good to talk about psych meds and other meds. It's good to talk about psych meds, again, with CSEC youth who might be in mental health treatment and prescribed medications as well. So a lot of times these things can be interrelated. If a parent, expectant youth, or with depression and they're pregnant, and these medications can have side effects that can impact the mother or the child or the birth process, is really important. Or with postpartum depression and things like that, psych meds are kind of interrelated with this topic. And so Michael, can you just talk about your role as a psych meds monitoring nurse, what you do, what you're looking for, and how our STRTP caregivers partner with you and the youth?
Yes, I definitely will. So I just wanted to say, when I first started with Fresno County a year and a half ago, I was a brand new public health nurse, but my background was in psychiatric mental health and nursing. So I had worked in a locked inpatient psych unit for many years with adults that are schizophrenics, bipolar, meth-induced psychosis, and any diagnosis you can think of. And so when I got tired of getting beat up by meth-induced psychotic patients, I decided I needed a change. And so I went for public health. And it just so happened that Fresno County was starting this new program where they needed a PMO nurse, psychotropic medication management and oversight. So it was like perfect timing for me. My boss thought I was a great fit for the position, so I got it. And so when I started, this program had never been here before, so I had to figure everything out as I went along. And so fortunately, Lupe had done the pilot program for 6 months, so I was able to pick her brain. And then Susan Bullard was a great help. She gave me the instructions on the JV220s, and she made herself available via email, phone. And I really picked her brain and asked a ton of questions to see how they did things in Madera County. And you as well, Anna. I had to reach out to you a few times when psychiatrists were over medicating the kids, and actually had one psychiatrist threaten to report me to the Board of Nursing. She didn't realize that my job is to provide oversight. And she said that I'm interfering with her job, and she wants to give a 5-year-old 3 medications. And fortunately, she resigned, so we no longer have to deal with her. She didn't appreciate the oversight. So she ended up going back to the prison, where her clients there will appreciate being over-medicated. So that was a good one. But one of the things that really stuck out to me, that really shocked me, I found disturbing, was these 5 and 6 and 10-year-olds are on more medication than my schizophrenic adults that have been schizophrenics their whole life. So I was like, something's not right. Why is this 5-year-old on antipsychotic? Why is he on Risperidol? Oh, they want to control his behavior. Okay, so they're chemically restraining these kids so that he doesn't lose placement. And that's not right. So one of the things I do is make sure that did he get therapy? Is he going to his weekly counseling meetings? So I can reach out to the care provider or the STRTPs and make sure that they're going to therapy. And sometimes I find out, oh, the kid's refusing, doesn't want to go or whatnot. So I just educate them on the importance and remind them that all of our kids have experienced trauma. If most of them were abused and neglected, but even if the only trauma they experienced was being removed from the home, that'd be enough to traumatize most kids. So we can all agree that 100% of our kids are traumatized. So they need help, they need therapy, they need to be able to relate to people. And in Fresno County right now, we have 250 kids on psychotropic medications, and just me. And so some of the challenges that I found were lab results weren't getting done. So, our medications can cause weight gain, they can cause the cholesterol to go up, they can cause all kinds of physical issues. And some of these meds need to be monitored, like your bipolar medications, like Depakote. Kids can get toxic very quick on Depakote. So when I started finding all the kids, because I had 250 kids, went down the list, prioritized which ones am I going to reach out to first, their providers. And for instance, a kiddo on Depakote, he had bounced around so many times, nobody bothered doing any labs. And so then you call this provider and that provider, oh, we didn't do it, they're going to do it, we're going to do it. And then they just keep giving you the runaround, and it takes forever to get the results. And then when you finally get them, you're like, oh, wow, look, he could be toxic right now. That could also be leading to some of his mental health conditions if they're toxic from the medications. And one kiddo we found, he was on like 2 antipsychotics, and his triglycerides were over 500 when they should be less than 90. So I had to reach out to one of the other public health nurses, and we got him a cardiology consult and got him into the hospital before he had a heart attack or a stroke. And so these are just some of the challenges. And when I do get a pregnant teen, I can refer them to Loopy. And also I reach out to the social worker to make sure they're getting a doctor's appointment, because some of the psychotropic medications can be harmful to the fetus. It can be harmful to the mother or whatnot. And so, and then the psychiatrist has to weigh out, is it, okay, is this child really suicidal? Are they going to hurt themselves? Do they need the meds? What's more important? So it's a really delicate balance that needs to be, they need to be evaluated. What else? So yeah, the other thing I would like to do is COVID really threw a monkey wrench into this whole PMO position, because right before COVID hit, I had a meeting set up with all 3 of the judges in Fresno County, and I was going to introduce my position to them and kind of pick their brains as what they would like to see, or just let them know about the resource, because then they canceled it. And I haven't been able to get a meeting since then. And now the courts have shut down. They're doing everything via Zoom. So it's a lot harder. And so I'm still working on getting that meeting with the judges just to see, because I know I talked to Susan. Madera, they do things a little bit different there. And she had a good rapport with her judge, and they really listened to her input. But so for now, one of the things I did prior to COVID was, when a psychiatrist orders too many meds, and I reach out to them and they pretty much tell me, I'm going to give these meds, you're just a nurse, what do you know? And so the only option I have is to submit a JV 222 to the court and let the judge and the courts know my side of the, what the state recommendations are. And so I actually got to go to court one time and tell the judge, what the state parameters were, and she sided with me. And instead of ordering the 5-year-old 2 meds, she only gave the kid 1 med. And so I thought that was a win, because, only 1 medication for a 5-year-old, and that's what the parameters call for. And our foster youth have stricter parameters than regular kids, because they have no one advocating for them. So that's why a lot of these psychiatrists that come from the regular world, they come into foster care, they want to prescribe to these kids like they did out there, but we have stricter guidelines. And we've adopted our guidelines from LA County. So thank you, LA, for the strict guidelines you have. And LA is actually doing a better job than Fresno. They have less percentage of kids on psychotropic meds than we do. So one of the goals I have is to reduce our percentages, but it's been pretty difficult. And now with COVID, all the kids are seeing the psychiatrist via Zoom, so height and weights aren't being done. So I can no longer track BMIs, and they're not doing labs. So it's very hard to get a lot of these things going again. So those are some of the challenges I face.
Thank you, Michael. I think
I-
that's a great example of how the nurses in our STRTP facilities can collaborate again with the public health nurse, because you can get height and weight in the home in the STRTP and then complete that picture because of the COVID environment that we have. So I think there's a lot of opportunities here for kind of best practice and safe practice if we talk to each other and support. One of the things I was just wondering if you could just kind of give a high level, you and I know what the parameters are, but if I'm a caregiver, there's a couple of kind of telltale signs that maybe it's time to call someone about the psych meds, or to question. It's a little bit hard when we don't know a young person's typical baseline behavior. They're newly coming into a home, and if they're off a medication, there can be withdrawal effects that can lead to certain behaviors that aren't ideal, right? So if we can train our staff to know that a child's behavior isn't really their personality, it could be a health issue that's going on that's impacting their behavior. When I was a teacher, I had to really question, like, is that kid lashing out or angry or upset because of that's who they are as an individual? No, it's because something's going on. And so I had this series of questions, and sometimes it was because of a psych med, or they're drooling on themselves, or their body is giving us a sign that something's not right. So can you just sort of tell us, like, what are the things to look for, or some red flags?
Definitely. A lot of our medications do cause side effects. So antipsychotics, for instance, cause what's called EPS, extrapyramidal symptoms. And so we've all seen the homeless person on the street that's doing the lip smacking, or the finger rolling, pill rolling, or they're twitching. Those are all signs that if they are on an antipsychotic, they could be experiencing EPS, and they would need to get into the doctor right away to get that taken care of. Also, internal restlessness, that's called akathisia. Some people mistake that for anxiety, but some medications can cause very bad restlessness. So there's medications that can help them to, relax. It's not really anxiety, but it's hard to tell the difference. So that's why you need to get them in for an evaluation if you notice anything different. Oh, one of the other things too, I'd like to point out for the STRTPs, it's very important. So we have a lot of over-the-counter medications. For instance, Benadryl, melatonin. Then you got some things for depression like SAM-E or St. John's wort. So if you try to just help this kiddo yourself and you put them on these things, well, they cause side effects, and they can interact with other medication that the child might be taking. It could actually cause death or serious harm. So it's very important that we know everything the child's taking, and they don't try and do a over-the-counter med without letting the psychiatrist know. In fact, we require that in Fresno, and I think every county is the same. We require any over-the-counter med that's used for sleep, sedation, psychotropic medications, whatever, that they be listed on the JV 220, and the judge has to approve them.
I just want to support some of the things that Michael said. I had a child come in one time and see me and had the lip smacking. And I reached out to the psychiatrist again, trying to form those connections and explain what was going on. And they just brushed me off and said, oh, we'll see him in a month. And being the proactive, I care about these kids like my own. I sent the child to the ER, and the ER doctor saw what I saw and stopped the meds so this child would not have a permanent disfiguring. So again, it's back to us looking at these kids like they're our own.
Yeah, and some, some side effects can even be lactation or breast growth, the weight
Mhm.
gain. These are things that the caregiver are more likely to see because you see them every day, or to notice. There can be, and if you know that they're using alcohol or other substances and on a medication, it's really important to maybe run that by a nurse, because again, there was an incident in Contra Costa where a young man died. He was on psychotropic medications, and as a teenager went to a party, drank some alcohol, and was kind of stumbling around, slurring speech, wasn't feeling well, but didn't get to the ER and actually passed away in their sleep from the interaction effects between the psych meds and alcohol. So even
Mhm.
things that we think this is like normal kid behavior to go to a party maybe, and but some of these things, the risks are a lot higher when you're on a psych med. So just to kind of, as a caregiver, be aware, and to kind of really do the linkages and use your support of the nurses in-house and the public health nurses whose role it is to oversee. And then Loopy, I'll have you go, and then I'm going to have Alyssa share next because she has a deadline to leave, but I do want her to share her in protocol.
I just want to say that Fresno County is so blessed to have Michael be part of our group. And also, when I was doing the PIMO pilot program, there was a youth that was on, she was over-medicated. And one of the symptoms that she had that we were made aware by the school nurse was she was urinating in her bed at night. And so the care provider was saying, oh, she's attention seeking by wetting her bed. And it was due to the medication that she was on, and she was on too many. So yeah, that's another example. But anyway, okay, I'm done.
Yeah, I think that's just an important thing. I think we have to question some assumptions, like, is this, a behavior issue, or is it linked to a health need, or a health side effect? And, we can read the drug labels of the drugs. You can call the doctor, you can call the public health nurse and just say, hey, I was noticing this. I think just having, to hold judgment or hold assumptions is something I really tried to practice as a teacher. Sometimes it can be hard. You're trying to teach a class, you're trying to, prove to your boss you're doing a good job, and the kid just can't learn that day because of something that's going on. And so, I really had to check a lot of assumptions, like, did you eat today? Did you have this? What's going on? To really get them to that point of safety and reassure them. So I know it's really difficult in the moment when you're dealing with a lot of folks in a home, and that's just kind of, I think, a practice we can all work on. I'm seeing my video is lagging. Can people hear me? Okay, so
Yes.
next I wanted Alyssa to share. I know Alyssa has to leave a little bit early, and then I'll have Cynthia share on COVID protocols, and then we'll go to breakout rooms. So next, Alyssa, I'm going to share my screen, but do you want to just talk through what Hillsides is doing with their initial medical screening?
Yeah, definitely. Hi, everyone. I'm a program manager at Hillsides. My position is actually to oversee and supervise the therapists and our behavior support staff. But we all work very closely with our nursing department. And this is our initial medical screening that we've been using for quite some time, and I've made some updates to it. I think I wanted to start by just sharing, like, right from intake, our new client comes in and meets with our intake coordinator and, signs consent forms, does all the intake paperwork, but then they immediately go over to the nursing department to do this medical screening. But I think that's so important, just because they can start to build that relationship with our nursing department from day one. And even though some of the questions could feel, sensitive or too personal, I think our nurses do a phenomenal job of just trying to build those relationships and get to know the clients right off the bat from day one. So as you can see, a lot of them are pretty standard questions, like height, weight, any allergies. At the top, we have preferred pronouns. I think that's really important to be asking our clients and making sure that you know, once you've received that information, that you then, you know, inform other staff or correct other staff if that does come up. So I think that's a really important section. I think I wanted to just emphasize actually the second page. So of course, most of these are pretty common medical questions: sleep, substance use. With substance use, we have substance use interns or substance use counselors, sorry, as well as we can contract out with for substance use groups. So I think it is a really good information to obtain from the client, or even from the social worker at intake if the client doesn't disclose anything. And with that information, the therapist can then try to connect them to a resource if needed. And then we have these two sections, female and male interview. You know, the female may be questions more specific to: have you started your menstrual cycle? Are you sexually active? Are you currently using any birth control? One question I did add is, are you aware of different products available for menstruation? I think that's important because some kiddos don't even know what's available, or they've been told they can't use certain things or can use certain things, or maybe they're afraid to ask. And so I think it's really important just to let them know what their options are, and maybe identify like a specific staff on campus over time that they feel trust with, and they're willing to ask them like, hey, can you hand me a pad before I go into the bathroom? So I think just developing those relationships with our staff are so important. And then the big section that I've edited over the past few months is the sexual health and reproductive rights section. So that's kind of what I wanted to emphasize today. This was not here prior to me adding it a few weeks ago. But I just think it's really important now with SB 89 that we're asking kiddos, have you had sexual health and reproductive education in school, you know, middle school or high school? Is there anybody you trust in your life you can talk to about this? If it's a yes, maybe like letting the therapist know, hey, in their medical interview with me, they identified their aunt as somebody. Definitely asking them, are you currently seeing anyone? And then if they'd like information about healthy relationships and dating, are you currently sexually active or considering becoming sexually active? And then of course a follow-up in regards to access to birth control. We have lots of condoms in the nursing office, and so we will happily give them out to anyone who asks, or even if they don't ask and they say I'm sexually active, I'll say, here, take some condoms. And then we actually just received in the mail some of these Know Your Rights brochures. So I want to start handing these out at intake for our new clients, just so that they can get a sense of like what their rights are as a youth. I believe these are similar to what Anna showed on our screen a while earlier in today's presentation in terms of like how to talk to kids. It's a similar brochure. And I think I just wanted to also emphasize, you know, our nurses get this information, and then part of my role is to oversee the therapists and behavior support staff. And with the behavior support staff, they're working a lot with the kiddos on teaching them about healthy relationships, about consent, maybe connecting them to Planned Parenthood, to set up appointments maybe for STI testing, or something the client's unwilling to talk to staff about, but they're willing to go to Planned Parenthood about. So I think we just look at it as like really a big multidisciplinary team of making sure whatever the nurses get, they let the therapist know. What if the therapist sees something or notices something about, like Michael was just talking about, a side effect in therapy session, that they go then tell the nurse. So I just think that the constant communication amongst all of our team members is super important in order to get this information and in order to share with clients, you know, information about their rights, information about birth control and healthy relationships. So I think hopefully this section I've added, we can start to use, and we can maybe get feedback from our kiddos on what they want with this section during the medical screening.
Great.
But yeah, any questions or thoughts?
I would just say here, the Know Your Rights brochure, many people in our learning community have worked with the Ombuds office. They're free. You can just kind of re-up when you're getting close to running out. You just email them and you say, you know, my name is, I need 100 brochures and I need them to address to, you know, Anna Johnson at this address. And the Ombuds office sends you those brochures for free. So, you know, I think that's just the only thing I'd say there is that this is a free resource. And it's everything in here is something that is tied to a caregiver's role in overseeing healthy sexual and reproductive care for the youth in care. So this is just, thank you, Alyssa, for sharing. And just to tie it back, you know, as Michael was saying about, are you coming in with medications, or, you know, we haven't been able to get labs or height and weight, but when you have this type of intake practice and work with the public health nurse, there's a whole picture then that can be input into the HEP, and it's a really strong partnership. So thank you, Alyssa, for working on this. Anyone who has questions, please type them in the chat or feel free to ask Alyssa right now.
I actually had something come to mind when Michael was talking in regards to like the court and connections with judges, and then what I really like to emphasize here at Hillsides is our relationship with clients' CASA workers. I think CASAs are incredible, and they've been able to build really wonderful relationships with their clients, and then really advocate to attorneys and work even closely with the social workers. But I've had some phenomenal CASA workers like be able to support with medication or just get a sense of medication awareness. So I think that that's just a really good resource that we have here in LA County.
Yeah, and CASAs have their own medication training that they developed with a grant from Kaiser. So most CASAs have been able to access that psych meds training. And so they can be a really good resource as well. Does anyone have questions for Alyssa? Can people beg, borrow, steal this, Alyssa? Is it proprietary? Do we need to ask for? So it is a resource. It's something that Alyssa has graciously shared. If anyone has use for it, questions, Alyssa is here as part of the learning community. So the final topic I wanted to cover was for Cynthia, did you have a question?
Yeah, and so I was just wondering, this is a very good, if you have an intake as detailed as this, it's a very good information because you're going to have a baseline of information for kids coming into your STRTP. Now, the only thing that I'm also gonna kind of say is that the importance of STRTP and caregivers to also make sure that any visit to the doctor or anything medically you know, done with the kids, that the records goes to the nurse. Because yesterday we do had some kid who have an annual or a visit to the doctor, which one of the PHN reviewed, and lo and behold, in conjunction with the psychiatric medication, and there are lots of things in there that we have to re-clarify. Like for example, the weight gain alone. From the date that that kid came into STRTP up to this point on, how much weight gain did that kid have? Because we kind of flagged out that the BMI was so high. Also, some of the labs in there. So it's very important that the HEP and all this medical information needs to be, given to the nurse to be reviewed. And that ties in. Sometimes you get the JV220, but yet in the annual or the medical visit, there's some more information in there that ties in to sometimes, oh, this kid has is taking some medication, and this is one of the side effects of the medication. Now, nurses usually call STRTP, hey, have you referred this kid to a cardiologist? Have you referred this kid to who's going to monitor this kid regarding, psychotropic, this psychotropic? We want to know. And okay, we found out that this kid has a tremendous amount of weight gain. Have you guys noticed that? Do we need to refer this kid to a dietitian or the GI? These are the things that's why it's very important that that medical record has to, be sent to us to make sure that we can evaluate, and so we can, look at what needed this kid needs regarding medical, and dental care.
Thank you. So really quickly before we move to breakout rooms, Cynthia also manages some COVID-19 response, and there is a draft all county letter coming out around COVID-19 for ages 16 and older receiving the vaccine. That the vaccine is a general treatment that a caregiver can refer for the youth, and so I think that's also important when youth come in and out of STRTPs and as part of COVID response, have they been vaccinated? Do they want to be vaccinated? We don't need to do it again if they've already gotten it, but or did they get one dose, get transferred, they need another dose? There could be, with just the way placement changes happen, it's kind of just important to note some of this, what's going on. And STRTPs have really been doing so much to change their practice and keep kids safe during this time and staff safe during this time and get staff vaccinated. So I don't think any of this is necessarily new, but I just wanted to flag this and have Cynthia share any kind of advice right now in this current moment of the pandemic.
Well, okay, with that kind, when the vaccine came out for 16 and older, now, talking to, I think, St. Anne, one of our provider, we have been, communicating with them throughout the pandemic to assist them. Now, one of our, as I said, our main goal, our main responsibility here is as a medical consultant to them. So we do help them. But one of the things that would be 16 and above, one of the things that we need to know is, have the kids been educated about the benefits of this benefits of the vaccine, because they're going to be the super spreader. They come in and out, they, go and visit their parents, they're, able in running away, coming back. So they can be a super spreader if they don't get this vaccine, but are they aware, that the importance of this vaccine? To them, peers is very important. So they will hear one of them say, I don't want to take that vaccine. And, to them, that's the most important that they will hear, rather than, okay, did the STRTP educate them on this? That the vaccine is effective in preventing COVID-19, that we protect not only yourself, but your family too. When you go on a home pass and coming back, you protect the others, because we don't, when they come back, are we gonna, quarantine them? So, it is very important to talk to them and how they can assist in preventing the pandemic, to stop the pandemic. That's one thing that I think, important for them to know, based on that. And also, what are you going to mention about the vaccination? If you decide the kid, okay, I want to be vaccinated, you got all the things, what are the things that you need to tell the vaccinator, or the importance of the data, like what are the allergies? Do they have fever? Do they have underlying conditions? Have you reached out to their primary provider to make sure that all these things that you know about this kid, before this kid goes and get the vaccination? And who are the ones who are not able to get the vaccine? So that's why it's sometimes important. Some of the STRTP have their own medical doctors already attending to all the kids in their side. So it's very important that they know that, especially the allergies, the underlying conditions, these are the things, important things that you need to let anybody know before they get that vaccine. And also the importance of the second dose. They might get the first dose and, hey, I'm already vaccinated, why will I get the second dose? You want to make sure that this kid know the importance of getting the second dose to be fully protected. And also the vaccine record, that's the most important too. This record needs to make sure that it goes into their file, and that record has to follow the kid wherever they go, because these kids move around. I remember when these kids come back and forth and they go to a juvenile and they cannot get the list of their vaccination, they just give them like hepatitis B. And lo and behold, when you look at them, they got what, 3, 4, I mean, or how many hepatitis B's are there? Because they can't wait where the vaccine is. I mean, their aim is to protect these kids too. So, you know, you get that kind of, you balance it. So it's very important. It's like the same as other immunization, that the record has to follow the kids wherever they go. And if you lost the card, you know where to do. The care system is there. And like after the vaccination, what are the common side effects? STRTP staff should know about the common side effects, what to look for. What is the immediate reaction on this kid to the vaccine? They need to know how to contact the 911 or what to look for. And what are the common side effects within 24 hours, 24 to 48 hours, and what to do. So that is in the website right now. You can download that, and you know, the aftercare of the vaccine. You know, so this is the most important thing that you also have to explain to the caregivers. And if a kid, there's also, if you really look at the website, there's the things that are, what are the risks of the Pfizer, because right now it's the Pfizer who's being offered to the 16 and above, right? And the common side effect of this vaccine is almost like, you know, what are the things. So a lot of the caregiver and STRTP, especially STRTP, also needs to educate their staff who will be caring for these kids after the vaccination. I think that's the, anyway, I think that's what, you know, I'm more concerned with this, you know, 16 to above, you know, who's going to get the vaccines.
Exactly. Thank you so much for sharing that, Cynthia. I don't see any questions in the chat, but could you put in that website that you were describing into the chat? Everyone, I was going to move to breakout rooms now. So in order to accept the rooms, we'll kind of go into smaller group discussions just to kind of talk or thank the nurses. But I'm going to open the rooms and you'll have to just click to join your room, and we'll start that now. So thank you everyone for our panel, and I'm pressing the button for the rooms. Okay, it looks like almost everybody joined the room. Cynthia, are you able to join a room, or are you logging off? Or, and then Nicole, let me chat you.